Okay, next one is it's going to talk to us about lateral complex injuries. Thank you very much, Dr. Fraser.
Thanks, Faiki. Right, so I'm going to talk about predominantly lateral condyle fractures, and there's not much to say about lateral epicondyle or capitellum, but we'll address those at the end of the talk. So this is the injury that we're talking about, the lateral condyle fracture. However, it's not always as obvious as this, and sometimes it can just be a subtle hairline fracture, which is easy to miss. As has been stated previously by Faiki, these are common around the age of 6, and they make up about 17% of distal humeral fractures. Usually there's going to be swelling and tenderness over the lateral aspect of the elbow, but these clinical signs can be subtle in the minimally displaced fractures, and they're usually isolated injuries. As mentioned previously, the radiological signs can be subtle. It can be helpful to do an internal oblique view to demonstrate the fracture. And one of the challenges is assessing the articular surface of the joint, which obviously is cartilaginous. And if there's any doubt, probably ultrasound, although there are some radiological markers which may be useful. And I would agree with Faiki that MRI certainly requires sedation. The services of an anaesthetist and is expensive, and arthrogram has pretty much the same limitations, purely as an investigative technique. I'm not going to cover this because Faki's already discussed the differences between distal humeral epiphysis displacement and lateral condyle fractures. So the traditional classification is the MILCH classification, which I don't find particularly useful. It's an anatomical classification as to whether the fracture line extends through the ossification center or more medially. And I think that the Jakob classification is more helpful because it has a bearing on your management. So stage 1 will be that fracture where the articular surface is intact. Stage 2, where the fracture will extend down to the articular surface, and you may not be able to see this, but there will be some subtle displacement of the ulna laterally, and then obviously the classical stage 3, where it is significantly displaced, often rotated, which can cause problems if this injury occurs in a rural setting and isn't treated, because obviously it's going to predispose to non-unions developing. So the treatment options, certainly if it is less than 2 millimeters, the fracture line is less than 2 millimeters displaced, then it would be quite acceptable to treat the child in an above elbow back slab for 4 to 6 weeks. And really what I need to emphasize here is it's imperative to do a check X-ray at 1 week to see whether the fracture has displaced. So in a recent meta-analysis in the JPO, when they looked at stage 1 fractures, they noted a 15% displacement of the fracture, and all of those occurred within the first week. So one really needs to do that 1 week check X-ray. And then you have to have some sort of assessment of the cartilaginous hinge. In other words, most of these are going to be intact. The internal oblique view may help you, and you might see more displacement than on a straight AP view. And as mentioned previously, arthrogram, ultrasound, or MRI if you have any doubts. Ultrasound probably being the most useful. So with these type 1 fractures, Finnbogasan had a look at these to try and ascertain which ones were more likely to displace. And certainly if you're looking at the scenario on your left where the fracture line, you can see that it's intact medially, they have no risk of displacing. I mean, these are obviously fairly subtle and they may not be clinically useful, but it is worth looking at them. The one in the middle, where the hinge seems to be intact medially, has a moderate risk of displacing. And then if there's significant fracture line extending all the way through, about 50% of those are likely to displace at a week. So we then come to closed reduction and percutaneous pinning. This is controversial. There are papers in the literature. It would be recommended for type 2 fractures. And the reduction technique is to flex the elbow, supinate the forearm, and apply direct pressure over the lateral condyle with your thumb. And then obviously you have to evaluate the quality of your reduction and the articular surface of the distal humerus with an intraoperative arthrogram. This has now been extended to type 3s. I don't think that I personally would recommend that. I think an open reduction and visualization of the articular surface is far better, certainly in my hands. And then that brings us through to open reduction and internal fixation. This is going to be applicable in the vast majority of lateral condyle fractures. In fact, this would be my option if I wasn't going to treat the patient closed. It's a lateral cochlear incision. One has to emphasize that you must try and avoid the posterolateral soft tissue structures, because this is where the vascular supply comes to the lateral condyle. And if you do a very vigorous dissection, you run the risk of avascular necrosis, which is obviously a disaster. You need to view the trochlea to confirm that you've got an anatomical reduction. And my preference is to use 2 slightly divergent K-wires inserted from the lateral side, although some authorities would recommend a partially threaded screw. So let's briefly deal with the complications, which are listed on the slide there, and we'll just go through them individually. Lateral spur formation can follow both conservative and surgical treatment. It's often present radiologically, but not usually of much clinical significance. It causes a pseudo-varus deformity because you have prominence of the lateral condyle, and it usually resolves with remodeling by the age of 2. So there you see an example of that lateral spur formation following a lateral condyle fracture. Elbow stiffness is usually not a problem following these injuries. It usually resolves within 4 to 6 months, and the only caveat that I would have with that is that if you're having a problem with elbow stiffness, then consider that you might be developing a delayed union of the fracture. Cubitus varus has been reported as being quite a high complication. It's usually not of concern. It may be due to inadequate reduction or growth stimulation. And surprisingly enough, cubitus valgus is very uncommon with the united fracture. But obviously it's a major concern when the patient has, when it's secondary to a non-union. So delayed unions, by definition, this is going to be a fracture which hasn't healed by the age of by 12 weeks. If it's stable, non-tender, and the range of movement is improving with time and there's no displacement, it will usually heal. But if that's not the case, then I think one needs to go in and do a delayed open reduction and internal fixation with K-wires, and beware of the risk of avascular necrosis. So non-union really is the major complication from this injury. We certainly would not want to be faced with this type of radiograph. Fortunately, they are rare. You're going to get a progressive valgus deformity. As a result of the valgus deformity, you can get a tardy ulnar palsy. And the problem is what to do with this. Sometimes they're asymptomatic, but they may be associated with pain and instability in the elbow. And the issue really is if it's long-standing, that you may not be able to get an anatomical reduction. So it really is a major problem. It has been recommended by Finn in the literature that if you are dealing with a large fragment which is displaced less than a centimeter and you've got an open physis, that it would be worthwhile, and you're likely to have a good result by going in and doing a open reduction, bone grafting, and internal fixation of the fracture. Sometimes it's not possible to get an anatomical reduction because you've now had remodeling of the bony fragments. You might have significant soft tissue contracture, and you might have to accept the fact that you're not going to reduce this fracture, but put it in a more acceptable anatomical position, and this can still be beneficial to the patient. I think that one should consider screw fixation in this scenario. You do want stable fixation. K-wires in my hands haven't been adequate. Fortunately, only about 20% of the growth in the upper limb takes place around the elbow, so there isn't a significant incidence of growth arrest, and I think you do need stability in this scenario. Then to deal with the cubitus valgus deformity, you may then have to go in subsequently and do a corrective supracondylar osteotomy to correct that deformity. And then, of course, the main issue with this is you have to avoid doing an extensive dissection to mobilize that fragment because of the risk of avascular necrosis. Then, if we deal with the fishtail deformities, there's two types which can develop. These are rare. There's a so-called sharp angled wedge where you have, a sort of angular deformity here in the articular surface of the joint, and this is either as a result of an articular malunion or a growth arrest. And both this and the second one, which is the more gentle, smooth deformity of the articular surface, secondary to predominantly avascular necrosis of the bone, have to be treated just along the normal lines of reconstructive elbow surgery. So if they're asymptomatic, obviously we won't do anything for them. The literature would suggest that there could be a role for arthroscopy. Certainly that's not going to be in my hands. And capsular releases if there's significant stiffness. There are one or two isolated papers dealing with this fishtail deformity where they have suggested doing growth modulation to prevent the deformity from getting worse. Quite impressive results, but nothing that I've fortunately had to deal with in my practice. Nerve injuries are rare and normally are in the acute setting resolve. In the chronic setting, as I mentioned before, with the progressive valgus deformity, but interestingly enough, they take a long time to present. So this is a sort of traction injury with the progressive valgus, and the average age of presentation is going to be 22 years. Now, just very briefly to end off with the other fractures on the lateral aspect of the distal humerus. Fractures of the capitellum are very rare in children. There have been a few isolated reports of sleeve fractures involving the capitellum. They may involve the metaphyseal bone or just be articular cartilage. And really, I think one treats those along the usual lines if the fragments are small, and you can reattach them with biodegradable pins, and that's an option, or you have to do an open reduction and fix them with cannulated screws from posteriorly, or you may remove portion of the articular cartilage and pretty drill the defect if that's appropriate. And then just to finish off with fractures of the lateral epicondyle, as isolated injuries are extremely uncommon. You have to just do an x-ray of the other side because there's a whole lot of variations of the ossific nucleus here, which can be normal. They can usually just be treated conservatively unless this fragment has displaced and is entrapped in the joint, when obviously one has to remove it. Thank you very much.